Well, thank you very much to all of you for coming. I know you must have had a very long day, as we did. It was a very long day for us too, so much appreciated that you're spending extra 90 minutes on adding extra 90 minutes to your long day. So the idea for the talk tonight is to combine a bit of information, of course, otherwise we wouldn't be here, with a bit of fun. So that's why we have this interactive voting system, which works primarily with multiple choice questions, but there are other ways to reply, but we'll guide you through. And we got also a nice break-in session just to test the devices. And obviously, it can be also interactive with direct questions. So if at any time you've got a question, just ask. And we will try to answer if it's possible. We got also some sweets here. So we will throw the sweets with the hard candies to all people who answered the right questions. So it's completely anonymous. I was joking. It's completely anonymous. So we don't know who's voting. We could find out if we wanted, but we decided not to. So it is completely anonymous. So the topic is the top 10 mistakes. They're actually a little bit more. They're probably 12, but they're all interlinked anyway, in the management of cardiac patients. And it's not that it's a way to reproach people for saying, oh, you've done this mistake. It's because we've been taught differently, and we all have made these mistakes, and we will go through these topics together. So to test your devices, if you got your mobile phones connected to Wi-Fi, right? So I've got the first question, which is, what is Magericophobia? Are there Greek people here? Yeah? No? So obviously they would have an advantage because it's a Greek word, but is it the fear of insects or spiders or rats, or is it just fear of cooking? Excellent. Oh well, it appears that majority of people know Greek very well, because indeed Magericophobia comes from Greek, and it means the fear of cooking. So it's the phobia of cooking, and it's a real pathology, believe it or not, reporting this publication, which I discovered incidentally. When I get bored, I just Google for weird stuff, and it is a real pathology where some people are just afraid of cooking scrambled eggs. Some people are scared of cooking for a big group of people, but it is something that is considered pathology when it interferes with their daily life. I'm Italian, and so actually I'm the opposite. I love cooking, and so for me this is something that I will never experience. Now, second question, are you aware that the RALPH has been accepting cardiology referrals for the last 12 months? Woo! Straight away. Okay, so there we go. There we go. Some people were not aware. Okay, so you are now. We do accept referral cases in cardiology, and obviously Heidi and I at the moment are doing a sort of job sharing, so we alternate, but we are always here, happy to take your case if you need any help. And within this service, I can actually stop showing the responses for a minute. Are you aware that we also accept referrals for outpatient services like echocardiography or an ECG without a consult? So for carers that have perhaps some financial constraint, they cannot afford a full consult, we offer just the diagnostic test, which is either ECG or an echo, and we obviously issue a full detailed report in each occasion. So apologies for this little advertising, but it's very important for us to become visible, because we are always very happy to help you with your clinical cases. Right, so now this is the first question. This is a thoracic radiograph, and it's obtained from a 7-year-old male Cavalier King Charles Spaniel with a loud murmur and cough. Does this image show evidence of pulmonary edema? Can you see well from the bottom, from the back? Yeah. Perhaps we can. Don't know whether we can switch off this light, but that's interesting. Ooh, now it's coming up. Oh, I like this. But certainly the majority of people would go for, yes, there is evidence of pulmonary edema, but just perihilar edema. Okay, so obviously, yes would be correct, because it implies that there is pulmonary edema. No, and I don't know, is a different way of interpreting this radiograph. So I haven't said who's right and who's wrong yet. So now you've got the possibility to touch your screen, your touch screen on your phone, and show me where you see the edema. And you can see, oh, the edema is appearing even in the liver. Okay, we got some hepatic congestion as well, which is probably true in this case. This liver is quite enlarged, so it might be possible there is some edema there too. Oh, you changed your mind, you went back.
Became refractory.
Huh?
Became refractory.
It became refractory. But I can see that, obviously we don't have the 25 people yet here on the screen, that the majority would see the edema in this region at this level. Right, so that's mistake number one. And that's a very common mistake. Perihilar edema is a wrong concept, pretty much. It derives from human radiology, and it refers to an edema, funnily enough, in the perihilar region. Now, what is the perihilar region in a human being? Well, first of all, you need a dorsoventral, well, back to front, I don't know how they call it in people, X-ray, because the hilar region is the point where the big vessels and the airway enter the lung. So there are two lungs, so we've got two perihilar points that we can only see in this view. And we can only see these points in the absence of significant cardiomegaly, because as soon as you got a significant cardiomegaly, these points are completely covered by the cardiac silhouette. Are you with me? Right, what we do in veterinary medicine, we tend to call the perihilar region, or the perihilar edema, the sort of opacity that appears behind the bifurcation of the trachea, which is not entirely correct. In order to see the perihilar region, we should refer to the dorsoventral view or ventral dorsal view, which in this case, for example, is impossible. You see how the cardiomegaly is actually masking the hilar points. So when I was training, so many years ago, my mentor had a lot of experience in cardiac angiography, because he started doing cardiology well before the availability of ultrasound and echocardiography. And so these are pictures from my mentor, Dr. Dark. This is a lateral view, chest X-ray view of a dog with mitral valve disease. And in the past, before the availability of Doppler echocardiography, the only way to prove regurgitation was to do a contrast angiogram. So that's the picture of a catheter coming from a carotid artery down to the brachiocephalic trunk into the left ventricle. And if you inject contrast medium in a dog with mitral regurgitation, you would expect the contrast medium to go into the left atrium, correct, because of the regurgitation. And that's exactly what this image is showing. But this is a mild regurgitation, and indeed you don't see a change in the silhouette, in the shape of the heart. So this would be masked by the heart in its normal shape. But as soon as we move to a more advanced case, and this is the case where perhaps most of us would say, oh, that's perihilar edema, I show you what that is. That's all left atrium. So the contrast medium now is injected into the left ventricle, and it goes into the left atrium. That is the perihilar edema that we wrongly interpreted on X-ray. So there might be perihilar edema, simply we cannot see it. So we need to be very careful not to overinterpret this sign, because this is just a sign of a big left atrium. There we go. So that's where we started with at the beginning. This dog was coughing, if you remember. And we're going to talk about cough again, because I'm obsessed about coughing, not just because of the coronavirus. I've been studying coughing for the last 20 years. to the point they said, don't ask Luca anything about coffee because otherwise you're stuck for 6 hours in the room. So this dog was coughing, certainly not because of the perihilar edema, because this dog does not have edema. This is all left atrium. Why is this dog coughing? Look at this bronchus here. It's completely squashed. And we could say squashed by the left atrium. Yeah, maybe is contributing, the big left atrium is contributing to the narrowing of the lumen of that bronchus, but because this dog has got bronchomalacia, so it's got loss of strength of the bronchial wall, which tends to collapse with the changes in pressure, intrathoracic pressure primarily, but also to a certain degree the left atrium can press on that bronchus, causing compression. And there are a lot of coffee receptors in this area, so this dog is coughing for that reason. So we can give all the furosemide we want. We might achieve some satisfactory results just with furosemide because we reduce the pressure in the left atrium, but that's not the way we treat bronchomalacia. We don't treat airway disease with diuretics. Right, so there was a very common misinterpretation, if you don't want to call it mistake, and I believe now it's, oh no, so are you going to talk at all tonight?
That was mine.
It is yours.
I'm excited, you just did it for me, thank you.
What, the sorry.
That's fine. Go ahead. You were enjoying yourself too much.
Right, are you sure you want to talk about this one? Okay, so we're going to introduce the concepts of tachycardia, bradycardia now. So the first question would be, what is the normal value in cats? And the second question, what is the normal value in dogs? So we can start with the normal resting heart rate in cats.
At home or at clinic?
Who said that? You're a very clever girl. I would say in clinics because I don't know many people measuring the heart rate unless you do home visits. So yeah, in clinic in our standard setting, but that's very clever. Okay, so majority would say probably 120 to 200, followed by 140 to 240, which is very similar. Okay, we're not very picky. We're not looking for the precise number. Besides, numbers in biology are often a cause of mistakes. Believe it or not, there are no studies available to prove the rate, the normal standard range of heart rate in cats in clinics. But in my personal experience, I think we are something between 140 and 240. 120 perhaps in a cat is a little bit too low. And some cats are extremely relaxed, so it could still be normal. But I think that these two answers are pretty much correct, but certainly up to 240 are, for me, at least in my experience, can be still normal. So I would say probably 140 to 240. But when we move to dogs, we do have 3 independent control studies. So I would like to know what your range, I think, is 40 to 120, 50 to 140, 60 to 170, or it depends on the size of the dog. You're going to comment on this?
Oh,
She's a nice display. Don't get to intervene at all. Okay, majority of people, more than 50%, would say it depends on the size of the dog. And that's absolutely correct if we refer to old literature. That's how I've been taught. That's what they told me at school. That depends on the size. So a large dog, like a Great Dane, would have a lower heart rate compared to a Chihuahua, for example, where the heart rate is expected to be higher. But there are 3 independent studies, and the first one is one we did together. So it was published in JSAP nearly 10 years ago. 10 years ago. Wow, time flies. And what we proved is that the heart rate is independent from the body size and the body surface area of dogs. And this was done with 2 different studies. One was prospective, so on physical examination of healthy dogs coming for routine examination for vaccination. And one was retrospective, based on ECG recording in dogs that were going for anesthesia, but for routine surgery like spaying or castration, so they were healthy patients. And you can see the line is almost horizontal, almost flat. So there is no association between body weight or body surface area in these animals. And the only difference we found is in very young puppies, where the heart rate tends to be slightly higher in a significant way, or in dogs that are nervous, aggressive, or particularly anxious. So that's the reason why dogs may have a different heart rate. It all depends on the demeanor. So don't get distracted. Yes?
Did you consider sighthounds separately or not?
Did I
Consider sighthounds separately or not?
No, we didn't have any. Yeah. So obviously we tried to get all the dogs that were coming through the door.
No, I just wondered.
No, we didn't have a specific breed we evaluated. What we tried, however, to differentiate was the cranial conformation, because there was a sort of a belief that brachycephalic breeds tend to have a lower heart rate, but we didn't find that. So no difference between mesocephalic, dolichocephalic, or brachycephalic. So the only difference we found. But this was our study. And this was published almost simultaneously to this study that was published in the United States based on 24-hour ECG. We were not aware, we just incidentally, the two papers came out together. So what they did here, they found that the minimum heart rate, the maximum heart rate, and the average heart rate during the 24 hours was not associated with the body weight either. So that was a sort of confirmation. And then a couple of years later, a paper coming from the RVC came with exactly the same result. They did find the statistical significance here, but it means that the statistical significance for no correlation. So it should be interpreted this way. It makes even stronger the fact that there is no association between heart rate and body weight. And this was based on a retrospective analysis on clinical records, so rather than, so it's not a control study. But you see, 3 studies proving the same. So, and you see that actually, in our paper, we found an average heart rate of 111, and Melanie's study, 108.5, so they're almost identical results. And the range is also very similar. We need to persuade Heidi to say something tonight.
I had about the first 20 minutes sorted.
Okay, so what is tachycardia then? I don't think we got... Oh yeah, we do have a question here. What type of heart rate response would you expect in a patient? Okay, so what is tachycardia? Let's go with this question then. What type of heart rate response would you expect in a patient with heart failure? Now, in heart failure, we got a sympathetic stimulation, a sympathetic overdrive. So you would expect to see tachycardia in all patients. And that's true when we talk about dogs. So in dogs, you would expect to see tachycardia. But somebody said, well, it depends on the species. Sure. In cats, it's the same. But some cats do not present with tachycardia, despite the sympathetic overdrive. And there are several interpretations for this. They present with a slow heart rate. And the first one, which is very likely, is a downregulation or misfunction of the baroreceptors that do not respond appropriately to the drop of the blood pressure. Or they may have conduction abnormalities, or they can have an atrial standstill or a slow atrial fibrillation. Very often we see atrioventricular block. So unless we ECG, we just find bradycardia. And that's quite typical of cats presented with, not typical, but possible in cats presented with heart failure. So if a cat presents with a breathing difficulty and you find a slow heart rate, don't get distracted by the fact that it's not tachycardic, okay? Because a big chunk of cats with heart failure will present with bradycardia. Heidi's doing this one.
Heidi's not supposed to be doing this one. Well, Heidi's now doing this one. Oh, you voted already? Okay, so what...
Let them play.
What is the normal mean resting respiratory rate in dogs and cats? More sweets. Okay, I think that's quite convincing. 20 for dogs and 25 in cats. And I go forward. Okay. So there have been a variety of studies done over the last few years looking at respiratory rates in different settings, both in sleeping and resting dogs and cats at home, in clinic. And this study here, published now, gosh, when was this? 2012, goodness me, looked at the comparison of the sleeping and the resting respiratory rates in dogs. So we can here see we have the age at the top with the scatter chart at the top and the body weight at the bottom. The sleeping respiratory rate there is shown, and we can see that there's no correlation here in terms of the age of the patient or the body weight of the patient, but that the mean is in the region there of about 20 breaths per minute. So at the top we have age, and the bottom we have body weight, and that's in 113 dogs sleeping. When we compare, however, to the resting respiratory rate, there is a difference. So there's some chart on the right-hand side shows the sleeping respiratory rate plotted on the left-hand side in dogs and the resting respiratory rate plotted on the right. And you can see and appreciate visually that the resting respiratory rate on average is generally higher than the sleeping respiratory rate. Now that's important when we're asking our carers to monitor their pets at home, particularly pets that are either in congestive heart failure and want to know how well they are controlled with the therapy, or pets that are maybe on the verge of going into congestive heart failure and we want to be able to monitor when that might have occurred. So we always recommend measuring the sleeping respiratory rate because it's more reliable and generally lower. Now when we've looked at cats, this study looks at cats in consultation rooms, so these are in-clinic cases. And we have here the
ambulatory. So that's
I'm trying to get this to work, it's fine. The ambulatory, no, it doesn't. So on the left, the APL stands for ambulatory respiratory rate, and then we have the resting respiratory rate in the centre and the sleeping respiratory rate on the side measured at home. And you can see straight away that there is a significant elevation in the ambulatory respiratory rate compared to in resting or sleeping rates. We're then looking on the right-hand side at a graph where these clinicians looked at two different ways of monitoring. They had the carers monitoring the patients at home, and then they asked them to make a video recording of what they were seeing and send that video recording then to the observer, which was the clinician, who verified what they believed the correct reading to be. And actually, there's a reasonable correlation, I think. There are a few outsiders.
I like to call it the
spaghetti
optimistic owner, and I like to be the pessimistic carer here, because obviously they overinterpret or underinterpret the correct measurement.
Okay, so we can see that obviously these cats need to be ideally sleeping, but at least resting to have a meaningful interpretation of their respiratory rate. Okay.
That's yours too.
So, this is a slightly different technique in terms of you don't vote for an answer. My question to you is, what to you does prolonged capillary refill time mean? And I want you to write an answer. And all those answers will then start popping up on the screen. So I want to hear what everybody believes prolonged capillary refill time indicates. Well, okay.
Wow, that's the first. Did you
Right.
Google first? Copy and paste.
Okay, great. So capillary refill time measurement is something that we all do. We were all taught to do it. What's the capillary refill time of the patient? Is it less than 2 seconds? Is it prolonged? Is it more than 2 seconds? Actually, in human medicine, it's something that is relatively rarely used, apart from in children. And in pediatric medicine, it is a technique that they use. But it's much more controlled in the recommendations of how it's applied, much more quantitative in terms of its assessment. This is just an example here of recommendations for the measurement of capillary refill time in children. They deem that it is likely to have some value, but we need to always be doing it in the same method. So the recommendation in children, they particularly use the finger. There are other areas, the chest, for example, the abdomen, and different areas they can use, but generally the finger is most utilised. And we should apply moderate pressure for 5 seconds on the finger, but then when we're looking at the capillary refill time, we need to quantify how long does it take for that to come back. Is it 4 seconds? Is it 5 seconds? Not, is it more than 2, for example? Okay, so it's a little bit ambiguous to use the terminology normal or prolonged. There's not a huge amount of evidence about the prognostic value in primary care settings in people, but they have been utilised. It has been utilised more in situations such as meningitis and sepsis and these sorts of cases. So I want you to look at both these videos. Okay, these are 2 patients of ours. Forget the colour of the mucous membranes. Okay, we have a very cyanotic patient here on the right-hand side, but I want you to tell me in a minute what your interpretation of the capillary refill time is in these 2 patients. Okay, which is the normal capillary refill time? Okay, happy if I move forward to the question? Okay, which of these 2 dogs shows a prolonged capillary refill time? I would agree with you. I totally agree with you. You're absolutely correct. Dog A has a prolonged capillary refill time. I'm going to tell you a secret. Dog B is a dead dog. Dog B was euthanized for a splenic hemangiosarcoma 10 minutes before this video was taken. So it's just an indication of how careful we have to be about utilising this parameter as an indication of perfusion, for example. Because it's extremely subjective and it can vary in different clinical settings.
Which of the following signs are suggestive of congestive heart failure? You can answer multiple questions because you can have multiple signs, of course, in heart failure. Shall we start commenting on these results? So majority, well, sort of, because we got the 3 together pretty much. Tachypnea, dyspnea, lethargy, absolutely right. These are all clinical signs that are associated with a congestive heart failure. In the absence of congestion, obviously lethargy would be the sign of heart failure. But in veterinary medicine, we use these 2 terms interchangeably. We say congestive heart failure, because when we see them in heart failure, usually they are in congestive heart failure. So we see them with tachypnea and dyspnea. But then I can see that, well, now is hypotension. I'm not sure about that, but cough is also there, and syncope. Well, I can tell you that cough is not a sign of congestive heart failure. Syncope is not a sign of congestive heart failure. Hypothermia could be in some cases. Hypotension, you need to have a very severe underlying cardiac disease to cause hypotension, because funnily enough, blood pressure is the most regulated parameter in our body. The body will always try to keep the blood pressure to normal values because the brain and the myocardium depend on the critical blood pressure, and the kidneys to a certain extent. So I just want to tell you why cough, which is reported in a lot of textbooks as a sign of heart failure, why is not a sign of heart failure. And so I did a study more than 10 years ago now to see what is actually causing cough in these dogs with heart failure, whether it's the pulmonary edema, which is the congestion, or whether they got underlying airway disease, and we have already introduced this concept earlier, or cardiomegaly. And what we found in 206 dogs with mitral valve disease, that approximately 50% of them cough and the other 50% don't. Those coughing, only 27% have evidence, radiographic evidence of congestive heart failure, while 68%, which is more than 2/3, have evidence of airway disease, radiographic evidence of airway disease. But most importantly, and then I'm glad that that was the winner of the question, all dogs that have congestive heart failure radiographically, namely pulmonary edema, have tachypnea or dyspnea. So that's the most specific sign of congestive heart failure. And so when we did the statistical analysis of all the different parameters that can cause cough, we found in the multivariate model, we found that actually pulmonary edema was the only one who did not have any effect in increasing the risk of coughing, while the presence of airway disease or the presence of a big left atrium would contribute to increasing the risk of coughing. But look at this. This is a sophisticated statistical analysis called an interaction. And it shows what happens when you've got a big left atrium in the absence of airway disease. Yeah, you can increase the risk of coughing by 2.6%. But in the presence of airway disease, the risk of coughing increases by 11 times, meaning that you need an underlying respiratory condition, and then the big heart contributes by adding extra stimulation of coughing receptors. So that's the truth behind the coughing dog with heart failure. So if the question is, why do dogs with heart disease cough? Is it because they got pulmonary edema without dyspnea? It's almost impossible. In order to have pulmonary edema, they need to present with tachypnea or dyspnea. But some dogs with pulmonary edema may also cough. Do they cough because of the pulmonary edema? Well, this is very rare. And this happens only when they build up such a large amount of fluid that it starts building up in the airways, and that's where the coughing receptors are, because there are no coughing receptors in the lower parts of the respiratory tree. Cardiomegaly without airway disease is, again, a very rare condition. And if you see a puppy, for example, with a massive heart, like in the PDA, for example, with the patent ductus arteriosus, they never cough. They very, very rarely cough despite a massive heart. But once they got cardiomegaly and airway disease, that's where they start coughing. So be very careful when you got a patient with heart disease coughing, because the answer or the explanation for the coughing is not in the pulmonary edema, is in the airway disease. So that's why I prepared this video. I'm very proud of this cartoon that I prepared for you. This boy has been forced to write for 100 times on the board that a coughing dog without dyspnea is not in congestive heart failure. And this should be a very important take-home message for those at least who voted or selected cough as a sign of congestive heart failure. So remember this, they need to have tachypnea or dyspnea.
I can do this one.
You need to click on the image to play the sound.
Okay.
We've got a sound here.
Okay, so hopefully the sound will work. So we have a little puppy here, which we're going to auscultate. Okay, so I'm going to play the sound of the auscultation, have a good listen, and then there might be a question. Okay, do you need to hear it again? You happy? No? Happy, okay. So, how would you describe the sound that you've auscultated in this puppy? Would you describe stertors or stridors, vesicular sounds, rhonchi, crackles, or wheezes? No, I still think crackles win. Okay, so roughly 60% of us say that they're crackles, 25-ish% rhonchi with a couple of outsiders as well. Okay. So what do you believe is the most indicative auscultatory finding in a dog or a cat with pulmonary edema? You can have multiple answers. Do you believe that it's increased lung sounds, crackles, no significant changes, gallop sounds, or rhonchi? Okay, so we've got roughly 40% saying crackles, and then we're up and down in between increased lung sounds and no significant changes.
Can you wait a second?
I can.
Who voted C? There you go. Again, no,
Okay, absolutely. That's what we expect to hear. Cases that present with a pulmonary edema tend not to present with crackles. They tend not to present with increased lung sounds. Instead, we don't really hear anything different. And in fact, you don't really hear anything, usually. The presence of hearing a crackle or a rhonchi would make you think usually of an underlying respiratory disease, not pulmonary edema. I'm going to
By the way, the puppy
explain rhonchi. Okay. So the puppy had rhonchi. Rhonchi is the sound of fluid moving through the bronchi. It's like a bubbling, gurgling sound. Okay. Crackles tend to sound more like a crisp packet rustling. If you think of those West Highland White Terriers that you're scrunching that crisp packet, they sound more like that. Now, there have been studies looking at the formation, the reason for crackles in dogs and in people. And this study looks at crackles in exercise normal dogs, in canine lungs. And what they have determined from these studies is that the sound of a crackle is actually due to the opening of peripheral airways, the very small bronchioles and the alveolar spaces during inspiration predominantly. And it's that sound of that sudden opening that produces the crackling sound. But they'll open in a rhythmical fashion, which is why we have that kind of ongoing crackle, crackle, one after the other. This has also been shown in people too, and again, this study looking at the mechanisms of both inspiratory and expiratory crackles show that the conclusion is that the most likely mechanism of the crackle generation is again this sudden airway opening on inspiration, causing this crackling sound.
So there's a collapse in expiration, and if we go back to can you go back to the puppy? Sorry to come back, but if we go back to the puppy there. You may notice that the sound here, which is big bubbles, so it's not crackles, is coming from the airways, not from the lungs, is both in inspiration and expiration. While crackles, for the definition that Heidi just explained, are primarily during inspiration. So you got the collapse in expiration and then the sudden opening of the airways, like a popping sound, but with thousands of alveoli and bronchioles that open in the following.
So if you hear crackles when you're ausculting your patients, try and identify, are they unilateral, are they bilateral, at what phase in the cycle, the inspiratory or expiratory, and that should guide you to thinking more of a respiratory origin for those crackles. And obviously if you're only hearing it unilateral, you may perhaps think of an infection, for example. If it's bilateral, it might be more generalized disease, but don't necessarily assume that that is pulmonary edema, because we wouldn't expect to hear that with pulmonary edema.
So, we've already started answering this question, but yes, I'm talking about bronchodilators now because we are moving from the bronchial sounds. You can answer multiple, you can choose multiple answers here. Okay, I think we are stuck here. So that's your choice. 42% will go for terbutaline, and that's in dogs, correct? Aminophylline and theophylline. Aminophylline is primarily theophylline, is a product we combine theophylline and another compound to increase the solubility, and salbuterol, albuterol, depending on where you are in the States or in Europe. So the right answer is E. None of the bronchodilators work in dogs. So bronchodilators simply do not work in dogs, and I explain why. Right. Do you know how a bronchodilator works? What is the principle, the mechanism of action?
Doesn't it not work on either the alpha or beta receptor or something?
Well, it depends on the compound, but what is the final mechanism? Say it again?
Inhibition of the
Phosphodiesterase, you mean?
Yeah.
Yes, but again, that's a pharmacological effect. But in terms of relaxation of the smooth muscle, very good, very good. So it's relaxation of the smooth muscle that is contracted. In order to be contracted, in order to be effective, you need to have a muscle that is contracted, because if it's not contracted, you don't relax anything, correct? It's like saying, I want to deflate a tire, but if the tire is flat, you don't deflate anything. And dogs do not have spontaneous bronchospasm. They never had in the history of nature. And that's the reason why, you can read these reviews available online, dogs cannot be used as experimental models for asthma in people, because they simply do not have bronchospasm, unlike cats. So there are two species, as far as I'm aware, that can experience spontaneous bronchospasm, and they are the cats and children, well, people, but primarily children are more affected than adults with, when they present with asthma. And there is another interesting study that was presented as an abstract more than 10 years ago at ECVIM, where they tried to induce bronchospasm in dogs by making them inhaling histamine. So there was a provoked bronchospasm, so not a natural bronchospasm. And they tried to prevent it with either theophylline or salbutamol. And they both failed. So even if bronchospasm was present in dogs, this drug would not work. And the reason is that the diameter, the caliper of an airway of a dog is massive compared to the size of the body. So if you show the X-ray of a dog, chest of a dog, to a human pneumologist, pneumatologist, they immediately say, your patient's got bronchiectasis, because the bronchi are so big compared to humans. And so even if you do have a minor degree of bronchospasm, as they induced with this plethysmography study, the change is very little. So it doesn't really affect very much the caliper of the airways. So just remove, my advice is remove bronchodilators from your armamentarium when you're dealing with respiratory disease in dogs, because simply they do not work. What you see instead is a lot of side effects, because these are nasty drugs, all of them, very nasty drugs, with the exception probably of salbutamol, because it's more of a local effect, because it's inhaled rather than systemic. But they cause tachycardia, they are causing anxiety, insomnia. These dogs pace at night a lot. We see a lot of ECG abnormalities associated with these drugs when they're given. So just stay away. That's my advice. Stay, do not touch them. By all means, in a cat with asthma, you can consider them, but do not consider them in dogs with respiratory issues.
Okay. So let's move away from dogs for the next few minutes and talk about cats. So my next question is, what's the most common cause of heart murmur in cats? What do you believe is the most common? Is it hypertrophic cardiomyopathy, HCM, restrictive cardiomyopathy, dilated cardiomyopathy, systolic anterior motion of the mitral valve, otherwise known as SAM, or dynamic right ventricular outflow tract obstruction, which we also call Dr. Vota as the acronym? 45% HCM, roughly 30-something% Dr. Vota, and we've got about 17-18% of people saying that we have SAM as the most common cause of murmur in cats. I just want to explain what SAM is. I agree, in my experience, SAM is one of the most common causes of heart murmurs that I see in cats. I see a lot of Dr. Voto too, but I think that SAM is the most common. Just to explain what this means, this is a dynamic obstruction to blood flowing out through the aorta. So looking at this picture here on the left-hand side, this diagram, I have the left atrial chamber at the top, the mitral apparatus there, the mitral valve separating the left atrium from the left ventricle. So the AML stands for the anterior mitral leaflet. In our patients, we will call that the septal mitral leaflet, and then the other is the parietal leaflet. Blood obviously travels from the left atrium through the mitral valve into the left ventricle. Mitral valve then closes. And during systole, the blood is pumped from the left ventricle out through the aorta, following that nice blue, non-turbulent flow that we are able to appreciate in that image. In cases of systolic anterior motion, there is an anomaly with the movement of the mitral valve itself. And the leaflet of the valve, the anterior leaflet, or the septal leaflet, as we call it in our patients, moves towards the interventricular septum during systole. And what that does is a little bit putting like a thumb over the end of a hose pipe. It causes a dynamic obstruction every time that happens, and it obstructs the blood flowing out from the left ventricle during systole into the aorta. So we end up with what we view on the Doppler image as this turbulent jet here. This is the left ventricle, this is the aorta here, and this is the left atrium and the mitral valve. But because this leaflet of this mitral valve here is displaced towards the interventricular septum when it shouldn't be, it's not in the correct position it should be. In other words, it should be closed during systole to prevent any backflow of blood back past the mitral valve, any mitral regurgitation, but that's not the case. It allows a concurrent mitral regurgitation. So we end up with a regurgitant jet flowing back from the left ventricle into the left atrium during systole, which gives us this classic double jet of blood turbulence and the resultant murmur from two causes, from the outflow obstruction through the aorta and the regurgitant jet back into the left atrium. And this phenomenon accounts for roughly 65% of all murmurs that we see in cats. Okay? So next question. The presence of SAM indicates what? You can answer multiple answers, sorry. Is it pathognomonic as a sign of hypertrophic cardiomyopathy? Does it represent a deformation of the mitral valve architecture? Does it occur during hyperdynamic states? Does it represent interventricular septal hypertrophy? Do we see it in cases of stress? Or is it secondary to degenerative valvular disease? I'm actually very impressed with that. That's an excellent answer. The only one of these that I would definitively say is not correct is A. Okay? SAM is not pathognomonic as a sign of HCM. We can have SAM in cases of HCM for sure, but it is not pathognomonic that whenever we see SAM, the patient has hypertrophic cardiomyopathy. This was something that for many years was put forward as a phenomenon that we were all taught, that if we had SAM, it was pathognomonic for HCM. Unfortunately, that isn't the case. In my experience, it is usually secondary to a deformation of the mitral valve apparatus. And so when we talk about the apparatus of the mitral valve, we don't just mean the leaflets, we mean, in addition to the leaflets, the papillary muscles, the chorda tendineae, and any one or multiple aspects of that apparatus can be slightly abnormal as a congenital anomaly. Usually, for example, the leaflet of the septal leaflet of the mitral valve might be a little bit too long, or the chorda tendineae might be slightly attached in the wrong place. Papillary muscle might be slightly misformed. These can all lead to or predispose this valve to having this abnormal motion. But certainly interventricular septal hypertrophy has been associated with these cases. Degenerative valvular disease, if congenital malformation is possible, then I believe that probably degenerative disease is also feasible in these cases. And it can be more pronounced in cases of stress and hyperdynamic states. So in a cat that is perhaps predisposed to developing this phenomenon, we sometimes see it worsening during hyperdynamic and periods of increased circulating catecholamines. So well done, very good. I'm going to pass to Luca for this one.
Okay. Yeah. The 65%, he didn't say, is not definitive. It's a study we got in progress based on approximately 1,000 cats we examined with heart murmurs. And at the moment, the abstract will be read at the end of this month, but that's where the number is coming from. Okay, well, you heard about iatrogenic murmurs. Who heard about iatrogenic murmurs? Did you throw a lot of candies here? Who voted A? You did. Oh, Rosie, again, there you go.
You told me about this.
Did I? Yeah. Did you? Oh, there you go. Anyone else? No? You don't want to? Anyway, they're here. You come and get yours because you deserve them. Okay, yeah, what are these iatrogenic murmurs? Well, when we auscultate a cat, and we hear a murmur on the right side of the chest, sometimes it's simply because we're pressing too hard with the stethoscope. Now, that's the cross-section of the base of the heart on ultrasound. So you see the aorta here, the left atrium, the right ventricle, and the right ventricular outflow tract down here. Now, that's where the probe is, and that's where the right ventricular wall, the muscle is. The distance is approximately less than 1 centimeter. So it's very easy to cause a pressure at that point with the stethoscope or with the ultrasound probe. So that's a phonocardiogram where I started pressing with the stethoscope at this point, and I generate the murmur between S1 and S2. And that's where I induce the murmur by pressing with the ultrasound probe. And you can see here, when I do the spectral interrogation, I can increase the outflow because of the pressure. It's like putting the thumb at the end of the garden hose, increase the velocity of the water jet, induced by my ultrasound. So these are not real murmurs. Well, they are real murmurs, but they're not naturally occurring murmurs. They're caused by us. So we need to be careful because it's approximately 18% of the murmurs we hear in practice. So they're caused by an overzealous, if you want, pressure with the stethoscope. So if it happens that you hear a murmur convincingly on the right side, just try to relieve the pressure a little bit. It doesn't need to be, you don't have to poke, just try to release a little bit. If the murmur disappears and you start hearing normal heart sounds, you got your diagnosis.
And similarly, with the SAM murmurs that we were talking about, don't forget to auscultate the sternum as well. Very often those murmurs are loudest actually slap bang in the middle on the sternum of the cat, not necessarily on the left side as you would expect to hear. So as Luca said, if it's right-sided, this needs to be considered, try to release the pressure a little bit, but if it's sternum, then I would always keep SAM in my thinking list at least.
So we presented this paper at ECVM last year, and is coming out soon in Journal of Veterinary Internal Medicine as a full article. And when the sort of rumor started spreading about iatrogenic murmur, our colleague Mark Rishnu from the United States, who you may know because he's always super active on VIN, decided to run this survey amongst cardiologists, and the question was, what do you believe causes iatrogenic murmurs in cats? And the answer is dynamic right ventricular outflow obstruction for the majority of cardiologists. But a big chunk, nearly a quarter, I don't know what that is. And we're talking about cardiologists here, not even practitioners, so people dealing with the heart murmurs on a daily basis. And when the question was, have you ever created Dr. Voto with an ultrasound probe? You see people say no, probably they never realized that, or I don't remember, and only 20% recognize this problem. So the answer is this one. That's our study where we measure the normal outflow without pressure, and then by gently pressing with the probe on the chest wall, we manage to increase the speed of the blood flow. So by doing that, we cause the turbulence and we induce the murmur. So that's another interesting thing, I believe. Okay, that's super new. It's not even published. It will be published in the next couple of weeks, hopefully. So the next question is it mine or yours? Yeah. Which of the following ACE inhibitors have demonstrated to increase life expectancy in cats with heart disease? And because we got several here, you can answer multiple. We can choose multiple answers. I think that the majority would say none of the above. And I'm quite pleased with this because it means that you've been informed about this publication, which came out only in September last year. And so this is actually a very old study, very old study. We did this study approximately, well, we started 20 years ago, and it was completed 15 years ago. And it was a randomized, placebo-controlled, multi-center, double-blinded study to see the effect of benazepam compared to placebo in the treatment of cats with heart failure, so they were on furosemide, or in cats in the preclinical phase, where obviously the endpoint would be the onset of heart failure. And unfortunately, the Kaplan-Meier curve of survival here shows that there is no statistical difference between the two. And therefore, it was a very disappointing outcome. But the drug company at that time did not want to publish the results 15 years ago. And only lately, there was also a change in, so the company moved to another company. So the management changed, and they said, no, this should be public domain. And so they allowed us to publish this paper. But as you can see, the result is not very positive, well, not positive at all. And therefore, we should probably not even consider ACE inhibitors in the management of cats with heart disease, because it would be a waste of money. Right.
Okay.
Oh, that's yours.
Yes. So, moving back to dogs. Okay. Have you all heard of the consensus statement for the management, diagnosis and management of mitral valve disease.
We should ask a different question. Have you ever had a Boehringer representative come into your practice? If the answer is yes, you heard about the consensus.
So more than 10 years ago, back in 2009, we had the first version of the consensus statement for the diagnosis and management of this disease. Basically, they put a group of eminent cardiologists, predominantly American, together in a room and said, you're not coming out until you have decided how we're going to stage and manage this disease. And we had a consensus published which gave us guidelines on how to stage mitral valve disease in dogs and then how we should be managing them at various stages. Now, that was back in 2009. A long time ago. 10 years is a long time in medical terms. We had a lot of other studies published during that time. So, of course, there were some game-changing discoveries and research that was done. Hence, there was a real need for an updated consensus statement. So back in 2019, last year, this second version, an updated consensus statement, was produced by the American College of Veterinary Internal Medicine. So this is what we are now using for the guidance of how to stage these dogs with mitral valve disease and how, therefore, to treat them. Now, the consensus statement talks about a variety of different pharmacological and non-pharmacological interventions in these cases. The drugs generally that we are more used to using at different stages of this disease may be pimobendan, benazepril, spironolactone, and of course a diuretic, furosemide or torazamide. So, I'd like to ask you, which of the following criteria should be met before initiating treatment with pimobendan in mitral valve disease stage B2? You can have multiple answers to this question. So, answer A, the patient has to have a murmur intensity of grade 3 or louder. B, they have to have an echocardiographic left atrial to aortic root ratio of the right side short axis view in early diastole of equal or greater to 1.6. Option C, a left ventricular internal diameter in diastole when normalized for the body weight of more than or equal to 1.7. So in other words, left ventricular dimensions greater than the published allometric scaling reference values. A vertebral heart score and radiographs of 10.5 or more than 10.5, or all of the above. Okay, I think that's interesting. So more than a third of people here would start pimobendan in a dog that just had a left atrial to aortic root ratio of greater than or equal or greater than 1.6. The correct answer is E, all of the above. Okay, these dogs should have a murmur of grade 3 or louder. Yes, they do have to have a dilated left atrium greater than a ratio of 1.6, but they must also have a dilated left ventricle. It's not sufficient to just have a big left atrium. You have to have both in these cases. Radiographically, vertebral heart score of more than 10.5. In the cases of not having echo available, obviously we strongly encourage an echo to stage these cases, but there are some guidelines in the consensus about other ways to measure vertebral heart score and whether that can be used independently, but the value increases above 10.5 in those cases. So all of these things have to be present together. Unfortunately, I see far too many dogs coming to me that have just received pimobendan, either because they have a murmur and they've never necessarily had an echo, or that they have supposedly left atrial dilation. Unfortunately, that's not what the EPIC study, which was the name of the study that this data derived from, is about. I'll leave you this one.
Oh, all right, okay. We talk about hyperthyroidism now. We had one case today, actually. And so what do you expect to find in a cat with hyperthyroidism? Left ventricular hypertrophy similar to HCM, or systemic hypertension, tachycardia, or myocardial ischemia. Okay, so if we refer to textbooks, you're all right. But if we refer to science, only C and D are correct. Now, let's look at the effect of the thyroid hormone on the cardiovascular system. Now, there are two effects of the thyroxine or thyroid hormone on the vascular system. The first is to increase the density of beta receptors. Therefore, any sympathetic stimulation, like exercise, for example, will induce vasodilation. And so if you have more beta receptors, the same stimulation will promote more vasodilation. And then we got another effect, which is direct this time, and is based on the level of adrenomedulin and other mechanisms, endothelin, etc. So the T3 can actively relax the smooth muscle of these vessels, causing vasodilation. So by two different mechanisms, thyroid hormones dilate peripheral vessels. So if they dilate peripheral vessels, they induce hypotension, not hypertension. And the reason why we do not see the hypotension, or if there is very mild, is because there is a simultaneous increased cardiac output. So the two counterbalance, because you know that the blood pressure equals cardiac output times total peripheral resistance. Oh, there we go. So if you reduce the total peripheral resistance, but we increase the cardiac output, the blood pressure remains pretty much the same. And there is a strong evidence, actually, even in veterinary medicine, but somehow we got stuck to the very first report in 1990. We're still going around and around to this finding, where in a study with only 39 cats, they found that 87% of hyperthyroid cats had a mean systolic pressure of 167, which for me is not particularly elevated either. But then later studies, they found that only 22% of hyperthyroid cats had hypertension. There was a bigger study. And then they found that in 23% of normotensive hyperthyroid cats, after treatment, the blood pressure increases. It should be the other way around, which means that you reveal the real vasodilatory effect of thyroid hormone. And then other papers like this one, only 7% of cats with hypertensive retinopathy had hyperthyroidism, and blah, blah, blah. So there is a strong evidence, even in cats, not just in humans, where hyperthyroidism does not cause hypertension. But we're still stuck to the very first report in 1990, and we keep thinking that hyperthyroidism causes hypertension. If they got hypertension, it's because they are unlucky. They got two conditions. So the bottom line is, first of all, hypertension is difficult to diagnose, and you would agree with me that there isn't a single method that is easy to use. But if they're hypertensive, very often it's not because of hyperthyroidism, it's more likely due to Y-coat effect. So they're stressy cats, and therefore their blood pressure increases because of the situation, not because of the condition. And that's in people. In people, they also found that there are no echocardiographic evidence of hypertrophy or simil ACM. So, and the same applies to our patients. I don't think I've ever seen an hyperthyroid cat with hypertrophy or concentric hypertrophy that resembles hypertrophic cardiomyopathy. If they do, it's probably because they got two different diseases. That's what we commonly see in cats with hyperthyroidism. This was a cat that had hyperthyroidism, was not treated for a variety of reasons, and that's how it presented. If you look at the M mode of this cat, this is the free wall, which is not moving at all. It's thin, it's dense, this is all dead tissue. So these are ischemic lesions, so they are myocardial infarctions that are very common in cats with hyperthyroidism. So if we move to a dog with hypothyroidism, now you got the answers. What do you expect to find? DCM type of myocardial changes, hypotension, bradycardia, arrhythmias. That was so easy to answer, wasn't it? If it doesn't cause hypertension, obviously it doesn't cause hypotension when it's less. Very good. And I'm with you, bradycardia, and that's the reason we saw before. So we got less beta receptors, but also there is an action of the thyroid hormone at the level of the autonomous nervous system. So there is an increased vagal tone in these dogs. But DCM type, I'm glad there's only 11% here, has been repeated and repeated over the years that dogs with hypothyroidism may have a DCM type of lesions. In reality, yes, the bradycardia is something we see very often, and be careful, it has to be a regular bradycardia, not a sinus arrhythmia. So a regular bradycardia like this, you see it in hypothyroidism, in hypothermia, severe hypothermia, brain lesions, hyperkalemia, and that's it. You don't see these bradycardias otherwise. So if you see something like this, 35 beats per minute in this case, and is a regular sinus rhythm, think about hypothyroidism in a dog. And then if you have a reduction in heart rate, you got a drop in cardiac output. But the stroke volume drops even more in this case because of the reduced contractility, so you got low cardiac output. But the blood pressure, as you said quite correctly, doesn't change because yes, we do have a drop in cardiac output, but then the total peripheral resistance increases and therefore the blood pressure is maintained normal. If you remember the beginning said, blood pressure is a very well maintained parameter in our bodies. And to finish this paper that was published 5 years ago in Doberman pinchers with or without dilated cardiomyopathy, with or without hypothyroidism, and they found no association between the two. And even when there was evidence of hypothyroidism and dilated cardiomyopathy phenotype, the administration of thyroid hormone, supplementation of thyroid hormone, did not solve the myocardial issue. So there is no association between the two. So the bottom line is that the diagnosis of hypothyroidism is difficult. Accurate diagnosis of DCM is also even more difficult. And bradycardia in the long term can induce myocardial damage, and therefore you can eventually see a diseased myocardium, but that's because of the volume overload rather than a primary effect. And we finished in time. I was very careful, not to go over the 90 minutes, but obviously we're here to answer your questions if you have any. And I was joking about who deserves the candies or not. They're here for you. So come and grab your packet of mini hearts.